Hello everyone. I'm Dr. Siddhi Chawla. I'm Assistant Professor in Department of Radiology in Sardar Patel Medical College. So today, I've been given this opportunity to cover the basics of chest X-ray, including the lines and tube that are important for you. So I hope I do a complete justice to it. So an overview, what are we going to actually cover? We will be covering the adequate technical factors, the lobar anatomy, and the imaging of collapse, the alveolar infiltrates, and some air at abnormal places, and the various lines and tubes that you come across in your basically ICU setting, right? So coming to the basics of chest radiography. So the basics projections that we take are the AP X-rays. AP is basically anterior to posterior. PA is posterior to anterior, and then we can take lateral decubitus in patients who cannot stand up. Right. So most of the times when you come across any patient in your ICU setting, most of the patients, they basically undergo an AP radiograph. Why? Because the patient is actually lying on the bed and we take an X-ray while the patient is in supine position. So the X-rays basically travel from anterior to posterior location. Right. So what are the various densities that you might come across in a chest X-ray? If it is purely white, then it is mostly bone or calcification. As you can see, this is a normal PA chest radiograph, right? It is always written on the chest radiograph. You can see that the bones are white. All the bones, the scapula, the clavicle, the vertebra, all are white. Then everything that is black is air, right? So this is basically, these are basically the lungs that are filled with air, so they appear black. You can also see that the that air is black also outside the body, right? It is so everything that is black on chest X-ray is actually air. Then gray is the intermediate tissue. Like you can see that this is the liver and this is the spleen, right? So they give an intermediate gray signal. And then bright white is actually the metallic objects that we might come across in some patient as artifacts or some foreign body that the patient has inhaled, right? So one of the most important things that I tell my radiology residents also, and I want all of you to keep in mind, is that there should be no rotation in the chest X-ray. The X-ray should be centered, right? The vertebral, the spinous process should be lined within the center and should be equidistant from the clavicle. And that is the accurate chest radiograph appearance. Because once the patient is rotated, like in ICU setting also, the patient is sometimes in a left lateral or right lateral decubitus, it basically distorts the images of the organs which are located within the chest, right? We might give a cardiomegaly when it is not present, or we might get a consolidation when it is not there. We might think there is a mediastinal shift when it is actually not there, right? So the center is also important. So this is basically an X-ray in which it is not centered, right? You can see that the spinous process are in the middle, while the distance from the clavicles, each end of clavicle is unequal, which tells us that the radiograph is not central, right? And so it gives us false interpretations, and we should always keep in mind while you're observing any chest X-ray. So this is another example of how the chest X-rays might look and give you a spurious findings when the patient is not centered, right? You can see that the clavicle is on the right side and the distance is unequal, right? So what do we see? We see a large heart, but in actual practice, it is not there, right? This can also be seen when the patient has not taken adequate inspiration, right? So you can see that the ideal number of ribs that we come across is the posterior 7 ribs should be seen. If they are less than 7, then it might be an inappropriate inspiration effect, right? Again, we come across the same similar findings. What do we see in this patient is that this is the chest X-ray when the patient is in expiration, and this is the chest X-ray when the patient has properly done inspiration. So we can see that the lung fields are better seen when the patient has taken a proper inspiration. So while you're in an ICU setting, most of the times the patient has a respiratory difficulty and you're not able to the patient is actually not able to do a X-ray in inspiration. So most of the times we get this expiratory film. And the problem with this film is that you might find cardiomegaly when it is actually not there. And sometimes you might feel that there is haziness in this area, right? The lower lobes, they become hazy when the inspiratory effect is inspiratory effort is not that adequate, right? So mediastinal widening, cardiomegaly, and lower lobe opacification. They are the three drawbacks of a X-ray with improper inspiration. So what is the definition of proper inspiration? You have to count the number of ribs, right? An adequate inspiration is 5 to 7 anterior ribs and 10 posterior ribs. If it is poor, if there are less than 5 anterior ribs, or hyperinflation when there are more than 7 anterior ribs. So that is one thing that you should keep in mind. Again, as I told you, there is difference in projection. This is the standard AP view and this is the standard PA view. So what are the differences? You see that the part of the human, basically, if you are doing an X-ray for any part of the body, the part which is closer to the, basically the cassette which they bring, the part which is closer to that, it shows basically the normal size, and the part which is away from it shows an enlarged appearance on a chest X-ray. So as we can see, if the patient is lying supine, and this is the patient which is lying supine, and the X-rays are coming from this. So here they turn the patient and they keep the cassette. So we know that the heart is lying anteriorly and the vertebrae are lying posteriorly when the patient is in this position. So what happens is that since the heart is away from the cassette, it becomes enlarged in a AP view, whereas the PA view gives the exact size of the heart, because if this is the basically patient stands and this is the cassette and the patient stands like this and the X-rays come from here, right? So the heart is actually abutting the cassette. So in this case, the heart appears to be normal. The other side effect of this is basically the vertebra. The vertebra are better seen in a PA view, because why? They are magnified, right? So these are the types of projections that you should keep in mind. You should not label these X-rays as improper. As you know, cardiomegaly, there is no cardiomegaly. And this lower lobe opacification is also commonly seen as the spurious finding in these AP chest X-ray view. But obviously, in an ICU setting, obviously you cannot avoid them. But then you should know that what are the drawbacks of it. You just cannot label every patient has a cardiomegaly, right? So coming to the penetration, a good chest X-ray is very important to report the pathologies, right? So proper penetration is that you are able to see the lung properly, right? And what happened in this X-ray is basically the power of X-rays was basically, we label it as KVP. KVP is the kilo voltage, and these are basically what makes it. It makes the X-ray of high power, right? So what happens is most of the X-rays that should be stopped by the soft tissues, right? The bones, whatever, this liver and the lung. So they are not able to stop these X-rays, and most of it actually passes through the soft tissue. And what happens is that we are not able to see the definitions of what are the pathologies in the lungs. For example, if there was a mass lesion or there was some consolidation in this area, we would actually miss it if the penetration is not good. So whenever you feel that the penetration or the quality of X-ray, most of these are done by technicians, right? So you should always get a repeat chest X-ray done, because a properly taken X-ray is the key to proper reporting, right? In an improper X-ray might get you a spurious finding. Someone might say that, okay, there is pneumothorax in this patient, but actually the problem is that the penetration has not been proper, right? So coming to the borders of the heart, in a normal chest X-ray, we know that the right heart border is formed by the right atrium, and the left margin is formed by the left ventricle, right? So these are the basics of chest X-ray anatomy that you should know. And this is basically the apex. This is called the base of the heart. This is basically the aortic arch. So these are the margins of the heart that are visible on a chest X-ray, right? I'll show you as we go through the pathologies. So this is the shadow of the aorta. This is the actual location of the aorta. This is the ascending aorta, and this is the descending aorta.